So what we'd like to start out with is the topic of comparative effectiveness, which Ernst & Young did a survey and a report recently, and they found that amongst executives and CEOs that the number one concern of executives was whether comparative effectiveness, which has been newly funded by the stimulus bill and the budget, will be sort of a Trojan horse to allow cost to be factored into whether therapies and drugs will be covered. And we'll start out with a video that was last week at the Senate Roundtable on Health Reform. And during the confirmation of Kathleen Sebelius, there was a Republican senator who had some comments on this topic. So we'll start out with that.
As well as my concern about the use of comparative effectiveness research to deny or delay health care to Americans under proposed health care reform. Comparative effectiveness research can be used to provide patients and doctors with information so that they can make informed health care decisions. But without appropriate safeguards, the government can misuse comparative effectiveness research to deny coverage. Unfortunately, Governor Sebelius' answers to my questions made it clear that the administration is unwilling to support pro-patient safeguards. She left me with no assurance that HHS, federal health care programs, or any new entity such as the Federal Coordinating Council will not use comparative effectiveness research as a tool to deny care.
To Sir Michael Rawlins here with his comments, and if you could maybe...
I don't need a PowerPoint. I think we'll drop the PowerPoint because I think it's probably better to just carry on off from what Kathy's been talking about. I think it's important to understand our healthcare system in Britain, which is based on a tradition of social solidarity, where our healthcare system is funded by taxation and has been for the last 60 years. There's very little insurance-based healthcare. Perhaps applies to about 5% of all healthcare in Britain, but the majority of it, the vast majority, is publicly funded. And like all other healthcare systems, we only have a finite amount of money for healthcare. We spend about half what you guys in America spend because our gross domestic product is about half. We can't afford to spend as much as you do. It would absolutely wreck us, particularly in the present financial circumstances that we find ourselves in Britain and elsewhere in the world. So we have to make sure that, we try and make sure that every pound we spend on healthcare goes as far as it can. And part of it is to increase the quality of care, part of it is to combat variation, inappropriate variation in healthcare, and we have to take into account value for money with the sort of things we do, whether it's using pharmaceuticals, whether it's opening new hyperacute stroke units, whatever it is, we have to try and get value for money. And that is one of the things that NICE does. It's not the only thing we do, but it is one of the things where we have to look and see whether new interventions, whether they be diagnostics or devices or imaging techniques or pharmaceuticals, whether they are both clinically effective and cost effective. And we do that at NICE, and we do that not ourselves. I don't make these sort of decisions. My board doesn't make them. They're all made by our advisory bodies, which are drawn from the National Health Service and from universities. The idea this is government making decisions is absolute nonsense. It's my colleagues, clinical colleagues from around the country, and there's no way I can put pressure on them. There's no way I can go into their meetings and say, the Prime Minister's been on the phone last night, I want you to say yes or no to this particular product. They would just walk out of the room and hold a press conference outside the door or outside in the street. It just wouldn't work that way. And we have also in many of our advisory bodies representation from the pharmaceutical industry or the relevant industry, from patient organisations, and with our guidelines we always have two patients themselves on our guideline development group. So that when we were, for example, doing a guideline on schizophrenia, there were two individuals who were in remission from schizophrenia, and they formed a very important part of the group. One of them actually, interestingly, was a clinical psychologist, very appropriate to be in that group. So we have to make hard decisions sometimes. We have to sometimes say that a particular technology may be clinically effective, but I'm afraid that the price that is being asked, it's not cost effective, and we have to say no. We don't do it actually all that often. We do it about 10% of the time. Most of the time we say yes, or in a subgroup of the indicated patient populations. And the idea that that there are millions of British people denied drugs is actually untrue. We say yes most of the time, and we get attacked for saying yes too, because the people who fund healthcare are also rather cross with us when we say yes, and so challenge it that way. So we get it both sides. But this isn't government making decisions. This is decisions made, as it were, by the people for the people. And it's ordinary people out there who help us reach what are sometimes very tricky decisions, but ones we have to take in the interests of everybody in Britain who seeks care from our healthcare system.
Okay. I guess I have a question for you. And it's interesting to have the transatlantic perspectives here. Do you feel, Sir Michael, that your healthcare is inferior to ours, that patients are denied drug-eluting stents or cancer-fighting drugs in an inordinate amount of time? Or how do you feel about the counter-argument that the U.S., because we pay more here, we're the breadbasket of innovation, and that if we aggressively controlled costs like the European countries did, the stream of innovation would dry up? And so I'm just interested in your take on that.
Well, two questions there. One is, I don't think it's sensible for any of us to compare our healthcare systems. They've all got their benefits, they've all got their faults. To say my dad's bigger than yours, it starts getting at that sort of level. So rather than compare healthcare systems, I think we need to learn from each other and take up the good things and avoid from each other the bad bits of it. In terms of the idea that America's spending on drugs and Europe's sort of getting the benefits of it, actually it's quite untrue. The prices of drugs at the moment, if you compare the list price in Britain with the ain't what's paid or the average wholesale price in America, are very, very similar. One of the things we do in Britain, much more than you do, we cut marketing costs in Britain, but we allow something like 27 to 33% of turnover for R&D purposes, which is actually pretty good. But we cap marketing costs at 6% of turnover. So we actually rather resent the idea we're sort of living off the backs of Americans' money and innovation. We think we pay our way along just as much as you do.
I've
noticed that, yeah.
I'd like to comment just on one difference that I think Sir Michael reminded me, and that is that I totally agree with the way that the analysis is done. The fact that there is a price that can be negotiated that across the board, in a sense, and regulation that can occur around the way in which marketing costs are allocated and so on. Of course, right now we're in a situation, putting aside the health care that's provided, even insurance regulation is very decentralized in this country. So even what's considered solvency, different definitions of what would be acceptable in one state versus another is still not, we don't have a uniform system, is I guess what I'm getting at. So the kind of situation you're describing, even with a decentralized and academic sort of an inclusive set of networks, because you're dealing with a much more singular, in a way, decision, across the board kind of decision. That's one thing. We don't even have the same prices here, as you know. Kaiser, Aetna don't pay the same prices for virtually anything. And Medicare pays a different price for everything. So it just becomes, to my mind, having worked in the Medicare environment for so long, the idea of even trying to do it is, at least in our current system, it doesn't really work. So if you start down the road of thinking about how would you do a NICE-like system here, you really have to rethink the entire healthcare system and sort of the social contract, as you say.